thanks for tuning in to Shannon and Veronica Know Everything. Today we're going to be going over a little hepatology pharm. We're going to go through some of the cirrhosis manifestations and their pharmacology, as well as hep C pharmacology. So to start off with, our first manifestation of decompensated cirrhosis is ascites, which is fluid buildup in the abdomen. So we have several ways to treat ascites. The first is going to be paracentesis. So you'll go in and you go like around the aces, around the belly button, like right here, and you just drain off all the extra peritoneal fluid that you can. I've seen up to like 9 liters run off, just like a shit ton. And then something with that is if you draw off more than 5 liters, you have to give albumin. The reason for this is that people need these proteins for transport, nourishment, whatever the fuck albumin does. So if you draw off too much fluid, you're drawing out albumin. So therefore you need to supplement the albumin if you draw off greater than 5 liters. You also could do TIPS. So this is a shunt. So if you have ascites, that's likely that you're going to get a lot of pressure put on the hepatic portal system, and you're going to have some portal hypertension. So one way to relieve that with the portal hypertension associated with ascites is to do the TIPS shunt. So that just takes fluid going into the liver and shunts it so that it bypasses the liver. Also, we want to do diuretics. So diurese, then you have to pull off as much fluid from the abdomen and avoid a varicentesis perhaps. So you'll do a combination of aldo, or spironolactone, and Lasix. So make sure you do them in a 10-to-4 ratio, or specifically 100 to 40 milligrams, up to the ratio of 400 to 160. So just remember on tests, if you can't remember 10 to 4, and I remember that the 4 is Lasix, because Lasix, the generic is furosemide, so 4 furosemide. The reason for this is that spironolactone is a potassium sparing, so it increases your potassium, and Lasix decreases your potassium. So we do it to balance the potassium out just perfectly. So, and then a salt restriction, less than 2 grams of salt per day. So that is going to be ascites. The next is spontaneous bacterial peritonitis. So if you have cirrhosis, your peritoneal cavity can sometimes become infected spontaneously with bacteria. So the treatment for this is going to be 5 days of IV antibiotics. So remember, there's 5 days in a week, so peritonitis, you only have Monday through Friday. And the antibiotics is going to be cefotaxime or ceftriaxone. And then you might need albumin as well if you have spontaneous bacterial peritonitis, but only if it's indicated if your labs are off. So if your serum creatinine is greater than 1, or BUN greater than 30, or total Bailey greater than 4. So remember 134. So if any single one of those 3 labs is out of range, out of these ranges, give the patient albumin. So once you have spontaneous bacterial peritonitis, if the patient is at risk for another episode, then you're going to want to do long-term antibiotic prophylaxis. So that's going to be lifetime Cipro or lifetime Bactrim. The next condition, this is going to be a manifestation of decompensated cirrhosis, is esophageal varices, which can hemorrhage. A risk for hemorrhaging is a red whale sign. I have no idea what that is. So if a patient has a variceal hemorrhage, there's 2 things you have to do. Stop the bleeding with a vasoconstrictor and then give them antibiotics, because we want to prevent that spontaneous bacterial peritonitis, because that can come from the varices hemorrhaging. So vasoconstrictors that we're going to use to stop the bleeding in the hemorrhage is octreotide, first line, and then vasopressin, second line if you don't have octreotide. And then I don't know what antibiotics, I didn't write them there, but up to 7 days of antibiotics, so make sure you look at those. And then once you have a hemorrhage from varices, you're going to want to prophylax. So there's primary and secondary prophylaxis. The one I just described is secondary prophylaxis. So you have a hemorrhage, then we're going to prophylax with beta blockers as well as an EBL, which is endoscopy banding. So you're going to put some bands around the endoscopy so the varices can't hemorrhage. And then if you have varices and you're at risk for having a hemorrhage, but you haven't had one yet, that's primary prevention. So you're going to do beta blockers or the EBL, upper endoscopy ring. Does that make sense? Cool. And then the beta blockers, it's nadolol. Yeah, I wrote that funny. Carvedilol or propanolol. So propanolol and the Danolol, whatever the fuck, those are non-selective beta, non-selective beta blockers. And then carvedilol is a beta and alpha blocker. So make sure you look at what the antibiotics those 7 days are, I'm not sure. So lastly, we have hepatic encephalopathy. So if your cirrhosis becomes decompensated, patient's confused, hepatic encephalopathy. So you're going to treat with lactulose plus or minus the antibiotic rifaximin. So the indication for rifaximin is if the encephalopathy is not improving with lactulose alone. And lactulose, we know, is a constipation med. It's a laxative. Lactulose laxative. And then I just want to briefly mention what TIPS is. So it's indicated in varices and ascites because both these conditions indicate or are associated with portal hypertension. So it's going to be a shunt going from your hepatic vein, which is draining your gut, to the liver. It's going to shunt from there to the, from the portal vein to the hepatic vein. So the hepatic vein is leaving the liver and going to your inferior vena cava. So just shunt to bypass the liver. The one danger that was really emphasized in the slides is that it can increase hepatic encephalopathy. So if your patient is confused, TIPS is not indicated. But the indications, like I said, varices and ascites with portal hypertension.
Alright guys, so I'll jump in really quickly and we'll go over hepatitis C treatment. So there's going to be 3 different categories. So to begin with, we have NS5B, B polymerase inhibitors, and these medications end in buvir. So the way we remember this is buvir. We then have the N53/4A protease inhibitors. These end in Provir. And then we remember this is prevent turning 34. So Provir, prevent, and then the 34. We then have the NS5A protein inhibitors, and these end in Asvir. So remember, 5 assholes, so 5 Asvir, assholes. And then we have ribavirin. And the mechanism of action here is that it inhibits replication of DNA and RNA viruses. Some contraindications would be women who are pregnant or partners of women who are pregnant. They would not work in these patients if they have hepatitis C. Other contraindication would be cardiac disease. So now we're going to move down to some drug interactions with hepatitis C treatment because there are a few. So some specific ones is sofosbuvir interacts with statins. So if a patient comes in, they are on a statin, you do not want to prescribe that one.
Every statin interacts with hep C except for sulfabuvir.
Okay, so just to fix what we just said, so every hepatitis C treatment actually interacts with a statin except sofosbuvir. So remember that. That's what you want to use. Another thing is patients who are using Vicura. Do you know what that is, Sham? Okay, well anyways, if you see that in a vignette, they have the most potential for drug interactions when it comes to hep C treatment. As far as somebody taking antacids, they can interact with ledipose, oh my gosh. Anyways, one of the Provirs and then the Buvir, so you gotta kind of separate those for 4 hours. If you remember back to our antacid medication, we actually mentioned this, so just kind of separating those from any other type of meds. As far as interactions with PPIs, there are 2 that are not recommended with the use of PPIs. So the sofosbuvir and velpatasvir. So just kind of remember those if you can.
I'm never gonna remember that.
Just some general tips. So always check drug interactions when starting any type of hep C treatment. Screen for current or prior hep B infection before starting anybody on hep C treatment. Some baseline labs, you're going to do your CBC, INR, your hepatic function panel, and then GFR. And then after 4 weeks, you want to recheck those labs, except for the INR is not necessary. And then you do want to discontinue any treatment if you find that the ALTs are increased tenfold after 4 weeks of treatment. Just to go over things, we went over hepatology and just some pharma associated to that. So thank you.